Welcome to our comprehensive guide on bacterial infections of the oral mucosa. In this video, we'll explore the main types of bacterial infections that can affect the mouth, their causes, clinical features, diagnostic methods, and treatment options. Understanding these infections is crucial for both healthcare professionals and anyone interested in oral health. We'll start by distinguishing between specific and nonspecific bacterial infections, then dive into key diseases like tuberculosis, syphilis, gonorrhea, impetigo, cat scratch disease, necrotizing ulcerative gingivitis, and noma. Let's begin by understanding what makes an infection specific or nonspecific in the context of oral health. Oral bacterial infections are categorized into specific and nonspecific types. Specific infections are caused by well-defined pathogens with characteristic clinical features, such as tuberculosis or syphilis. Nonspecific infections like acute necrotizing ulcerative gingivitis result from a mix of bacteria and often depend on the host's immune status. Recognizing the difference helps guide diagnosis and treatment. For example, a specific infection may require targeted therapy, while nonspecific infections often need broader management, including improving oral hygiene and general health. Now, let's look at tuberculosis, a classic example of a specific oral infection. Tuberculosis, caused by Mycobacterium tuberculosis, is a serious infectious disease that primarily affects the lungs but can also involve the oral cavity. The bacterium is aerobic and acid-fast, making it resilient in the environment. Transmission occurs mainly through respiratory droplets, which is why pulmonary tuberculosis is the most common form. Oral manifestations are rare and usually occur as a complication of pulmonary TB, especially in immunocompromised individuals or those with chronic untreated disease. Let's explore the characteristics of the tuberculosis bacterium and how it impacts the body. Mycobacterium tuberculosis is a rod-shaped, acid-fast bacterium with a unique cell wall rich in mycolic acids, making it resistant to many common disinfectants and antibiotics. It divides slowly but can survive in the air for extended periods. The bacterium's antigenic structure includes lipid, protein, and polysaccharide components, which play roles in immune response and hypersensitivity reaction. The slow growth and resilience of this bacterium are key reasons why tuberculosis can be difficult to eradicate and why it remains a global health concern. Tuberculosis infection begins when the bacteria enter the body, usually via inhalation. The initial infection may remain latent, but if the host's immune system weakens, active disease can develop. The number of bacteria and the host's resistance determine whether disease occurs. Most cases involve the lungs, but the bacteria can spread to other organs, including the oral cavity. Oral TB typically presents as a chronic painless ulcer with irregular borders, often on the dorsal tongue or lips, especially in patients with HIV or chronic pulmonary TB. Tuberculosis remains a significant global health issue. According to the World Health Organization, in 2017 there were 10 million new cases worldwide, with a notable proportion co-infected with HIV and a growing number of multi-drug-resistant cases. In Vietnam, there were 126,000 new cases and 12,000 deaths reported in the same year. Oral TB is rare, but when it occurs, it is usually a complication of pulmonary TB, often seen in immunocompromised individuals or those with chronic, untreated disease. Oral tuberculosis typically presents as a single ulcer, most often on the dorsal surface of the tongue or the lips. The ulcer has irregular, ragged borders, is usually painless, and has a granular base that resembles glue. Regional lymph nodes may be enlarged. In patients with HIV/AIDS, multiple oral lesions may be present. These ulcers are often mistaken for other conditions, making clinical suspicion and proper diagnosis essential. Diagnosis of tuberculosis relies on both clinical and laboratory findings. Patients may present with persistent cough, low-grade fever, night sweats, chest pain, fatigue, and weight loss. Chest X-rays and sputum analysis are key investigations. Ziehl-Neelsen staining detects acid-fast bacilli, while cultures on Lowenstein-Jensen medium confirm the diagnosis. Additional tests include the Mantis skin test and GenX-BRT for rapid detection of drug resistance. Biopsy of oral lesions may reveal characteristic granulomas. When a biopsy is performed on an oral tuberculosis lesion, microscopic examination typically reveals granulomas with central caseous necrosis, surrounded by epithelioid cells and Langerhans giant cells. This classic histological appearance helps distinguish TB from other causes of oral ulcers. Identifying these features is crucial for confirming the diagnosis and guiding appropriate treatment. Primary treatment for tuberculosis is systemic, focusing on the lungs. Standard anti-TB medications include rifampicin, isoniazid, ethambutol, streptomycin, and pyrazinamide. Local treatment for oral lesions is generally unnecessary. Prevention strategies include BCG vaccination, limiting exposure to infectious sources, and improving overall health. Early diagnosis and adherence to treatment are vital to prevent complications and transmission. Syphilis is a sexually transmitted infection caused by the spirochete Trepomapulidum. Discovered in 1905, this bacterium is primarily transmitted through sexual contact but can also be passed from mother to child. Syphilis progresses through 3 stages, each with distinct oral manifestations. Recognizing these stages is essential for timely diagnosis and effective treatment. First stage of syphilis appears about 3–4 weeks after infection, often as a firm, painless ulcer known as a canker. In the mouth, cankers typically develop on the lips or tip of the tongue. The lesion starts as a raised nodule, then ulcerates with a hard base resembling carcinoma. Regional lymph nodes may also be enlarged. If untreated, the canker resolves on its own within weeks, but early treatment at this stage is highly effective. Diagnosis of primary syphilis can be challenging, as serological tests may still be negative. Direct detection of Treponema pallidum from the canker using dark-field microscopy is the most reliable method at this stage. Early identification is crucial, as treatment is most effective before the disease progresses. If left untreated, the infection enters a latent phase before advancing to secondary syphilis. Secondary syphilis develops 1–4 months after initial infection. Patients may experience fever, malaise, sore throat, generalized lymphadenopathy, and a characteristic skin rash, often on the back and chest. In the mouth, lesions may appear as patches or papules that quickly ulcerate and develop a grayish-wet membrane. These oral lesions are highly infectious. Over time, symptoms may fade and the disease enters a latent phase that can last for years. After the secondary stage, syphilis may enter a latent phase during which there are no visible symptoms but the bacteria remain in the body. This phase can last for years, and without treatment, the infection may progress to the tertiary stage, causing severe complications. Regular follow-up and serological testing are important for monitoring and managing latent syphilis. Tertiary syphilis can develop years after the initial infection if left untreated. In the mouth, it manifests as gummas, firm, rubbery masses that primarily affect the tongue and palate. These lesions can ulcerate and expand, potentially destroying surrounding tissues and even perforating the palate. Tertiary syphilis also affects the cardiovascular and nervous systems, leading to life-threatening complications. Congenital syphilis occurs when Treponema pallidum is transmitted from an infected mother to her child. This condition causes severe irreversible damage to the child's face and teeth. Hutchinson's triad inner ear abnormalities, deafness, interstitial keratitis, eye inflammation, and notched widely spaced teeth is characteristic. Other signs include short fifth fingers, Du Bois sign. Early detection and treatment during pregnancy are essential to prevent these outcomes. Syphilis diagnosis involves direct detection of the spirochete in tissue samples using dark-field microscopy, where Treponema pallidum appears as a spiral-shaped organism. Serological tests such as RPR, VDRL, TPHA, and FTABs are used to confirm infection and monitor treatment response. Accurate diagnosis is crucial for effective management and prevention of complications. Syphilis can mimic other diseases, making differential diagnosis important. In the primary stage, it may resemble Behçet's syndrome or genital herpes. Secondary syphilis can be confused with drug reactions or fungal infections, while tertiary syphilis may be mistaken for tuberculosis or oral cancer. Careful clinical evaluation and laboratory testing are essential to distinguish syphilis from these conditions. Mainstay of syphilis treatment is penicillin, specifically benzathine penicillin G. Alternative antibiotics like erythromycin, tetracycline, or ceftriaxone may be used in cases of allergy. Early treatment is highly effective and prevents progression to later stages. Regular follow-up and partner notification are important to control the spread of infection. Gonorrhea caused by Neisseria gonorrhoeae is another sexually transmitted infection that can affect the oral cavity. Transmission occurs through oral genital contact or sharing personal items. In the mouth, it presents as redness, pain, and white or yellow patches on the throat, tonsils, or tongue. Cervical lymphadenopathy may also be present. Gonorrhea can be mistaken for fungal infections or streptococcal pharyngitis. Diagnosis of oral gonorrhea involves microscopic examination of smears, where the bacteria appear as gram-negative diplococci inside and outside neutrophils. Culturing on Thayer-Martin medium confirms the diagnosis. The bacteria often appear as paired, coffee bean-shaped organisms. Accurate identification is essential for proper treatment and preventing complications. Gonorrhea is treated with antibiotics such as ceftriaxone, cefixime, doxycycline, or azithromycin. Prompt treatment is important to prevent complications, which can include pelvic inflammatory disease in women and epididymitis in men. Reinfection is possible, so safe practices and partner treatment are recommended. Impetigo is a highly contagious skin infection, most common in children, caused by Staphylococcus aureus or Streptococcus pyogenes. It often develops around the mouth following minor trauma or poor hygiene. The infection starts as blisters that become pustular, then rupture to form honey-colored crusts. Patients may experience itching, fever, and swollen lymph nodes. Treatment of impetigo includes local care with diluted potassium permanganate or saline and topical antibiotics like mupirocin. In more severe cases, oral antibiotics such as cefixime are prescribed. Good hygiene and avoiding sharing personal items are important to prevent spread. Most cases resolve with proper treatment, but complications can occur if left untreated. Cat scratch disease is caused by Bartonella henselae, typically following a scratch or bite from a cat or other animal. It is most common in children. The infection leads to a papule at the site of injury, followed by regional lymphadenopathy, mild fever, and sometimes conjunctivitis. The disease is usually self-limiting but can cause complications in immunocompromised individuals. Diagnosis is based on a history of animal exposure, clinical features, and exclusion of other causes of lymphadenopathy, such as tuberculosis or cancer. Laboratory confirmation may involve special stains to detect Bartonella henselae. Most cases are mild, but antibiotics like trimethoprim sulfamethoxazole may be used in severe or persistent cases. Necrotizing ulcerative gingivitis, or NUG, is an acute, destructive infection of the gums caused by a combination of spirochetes and fusiform bacteria. It often affects individuals with poor immunity, high stress, or underlying conditions like HIV. The disease starts at the interdental papillae, causing severe pain, foul breath, metallic taste, and ulceration covered by a gray pseudomembrane. Systemic symptoms like fever and cervical lymphadenopathy may also occur. Patients with NUG experience intense pain, spontaneous bleeding, and rapid destruction of gum tissue. The disease can progress to involve the underlying bone, leading to necrosis and sequestration of dead bone fragments. Prompt recognition and treatment are essential to prevent severe complications and restore oral health. Treatment of necrotizing ulcerative gingivitis involves local debridement, mouth rinses with diluted hydrogen peroxide or chlorhexidine, and systemic antibiotics such as metronidazole to target anaerobic bacteria. Supportive care, including pain management and improved oral hygiene, is also important. Early intervention can prevent progression to more severe disease. Noma, also known as cancrum oris, is a devastating infection that causes rapid and severe destruction of the oral and facial tissues. It is most common in malnourished children aged 6–10 years, especially those with weakened immune systems or recent illnesses like measles. The disease often begins as NUG and quickly progresses to involve the cheeks, lips, and jawbone, leading to large areas of tissue loss. Noma is caused by a combination of bacteria, primarily Fusobacterium necrophorum and Prevotella intermedia, interacting with other oral pathogens. The infection leads to necrosis of the oral mucosa and underlying bone, resulting in severe facial deformity. Early recognition and aggressive treatment are critical to improving outcomes and preventing death. Let's review the main features of the bacterial infections discussed so far. Tuberculosis is caused by Mycobacterium tuberculosis, syphilis by Treponema pallidum, gonorrhea by Neisseria gonorrhoeae, impetigo by Staphylococcus aureus or Streptococcus pyogenes, cat scratch disease by Bartonella henselae, NUG by Borrelia vincenta and fusiform bacilli, and Noma by a mix of anaerobic bacteria. Each infection has unique transmission routes, clinical features, and preferred treatment. Understanding how these infections are transmitted is key to prevention. Tuberculosis spreads via respiratory droplets. Syphilis and gonorrhea are primarily sexually transmitted. Impetigo is spread through direct contact or contaminated objects. Cat scratch disease follows animal scratches. NUG is linked to poor immunity and hygiene, and Noma is associated with malnutrition and systemic illness. Preventive strategies must be tailored to each infection's mode of transmission. Herd populations are at higher risk for these infections. Children are more susceptible to impetigo, cat scratch disease, and Noma. Immunocompromised individuals, such as those with HIV, are at greater risk for tuberculosis, NUG, and Noma. Poor hygiene, malnutrition, and chronic illnesses further increase susceptibility. Recognizing these risk factors helps guide public health interventions and clinical care. Oral bacterial infections present with a variety of lesions. Tuberculosis causes chronic ulcers with irregular borders. Syphilis produces painless cankers and gummas. Gonorrhea leads to red, painful patches. Impetigo forms honey-colored crusts. Cat scratch disease results in papules and lymphadenopathy. NUG causes painful, ulcerated gums, and Noma leads to massive tissue loss. Accurate clinical assessment is essential for diagnosis. Any oral bacterial infections are associated with lymphadenopathy. Tuberculosis and cat scratch disease often cause regional lymph node enlargement. Syphilis may present with localized or generalized lymphadenopathy depending on the stage. Gonorrhea and NUG can also cause cervical lymph node swelling. Recognizing these patterns aids in differential diagnosis. Laboratory tests are crucial for confirming the diagnosis of oral bacterial infections. These include special stains, Zeal-Nielsen for TB, Warthin-Starry for Bartonella, cultures, serological tests, RPR, VDRL for syphilis, and molecular assays like GeneXPRT. Biopsy and histopathology are also important for distinguishing between similar-appearing lesions. Oral bacterial infections can mimic other diseases, making differential diagnosis essential. For example, syphilitic cankers may resemble carcinoma or herpes, secondary syphilis can look like drug eruptions or fungal infections, and tertiary syphilis may be confused with tuberculosis or cancer. Careful clinical evaluation and appropriate laboratory tests are necessary to avoid misdiagnosis. Left untreated, oral bacterial infections can lead to serious complications. Tuberculosis may spread to other organs, syphilis can cause cardiovascular and neurological damage, gonorrhea may result in pelvic inflammatory disease or epididymitis, impetigo can cause deeper skin infections, and Noma leads to severe facial deformity and even death. Early recognition and treatment are vital to prevent these outcomes. Treatment of oral bacterial infections is tailored to the specific pathogen and disease severity. Antibiotics are the mainstay for most infections, with choices guided by sensitivity patterns and patient allergies. Supportive care, including pain management, oral hygiene, and nutritional support, is also important. In severe cases like Noma, surgical intervention may be required. Preventing oral bacterial infections involves vaccination such as BCG for tuberculosis, practicing safe sex, maintaining good oral hygiene, avoiding sharing personal items, and ensuring proper nutrition. Public health measures, early diagnosis, and prompt treatment are essential to control the spread of these infections and reduce complications. In summary, oral bacterial infections are diverse in their causes, clinical presentations, and management. Early recognition, accurate diagnosis, and appropriate treatment are critical to preventing complications and improving outcomes. Understanding the risk factors and transmission routes helps in both clinical practice and public health efforts. Stay informed and proactive to protect your oral and overall health. For those interested in learning more about oral bacterial infections, consult reputable medical textbooks, guidelines from the World Health Organization, and peer-reviewed articles. Staying updated with the latest research and recommendations ensures the best care for patients and helps in the prevention of these potentially serious diseases. Thank you for joining us on this journey through the world of oral bacterial infections. By understanding the causes, clinical features, diagnosis, and treatment of these diseases, we can better protect ourselves and our communities. Remember, maintaining good oral hygiene, seeking prompt medical attention for suspicious lesions, and following preventive measures are key steps in safeguarding oral health.